Welcome, curious minds, to the deep dive. Today we're embarking on, well, a monumental journey, a really intensive exploration into the body's incredibly intricate network of vessels to vasculature. Think of it as the ultimate, highly optimized plumbing system that keeps every single cell in your body thriving. Our mission today, drawing from the fundamental concepts in BERNE and LEVY physiology, is to take a deep, comprehensive dive into the physical properties of blood vessels and the blood itself. We want to truly master the principles of hemodynamics. Then, we'll pivot to explore how this remarkable circulatory system adapts and, operates in specific organs, from the tireless heart to the brilliant brain and far beyond. Get ready for some profound insights, because by the end of this deep dive, our goal is for you to understand this complex system like an elite professional in the field.
Precisely. And what's truly captivating here is how a few, seemingly simple physical laws underpin the incredibly complex and absolutely vital process of blood flow throughout your entire body. We're going to connect the dots between the mechanics of fluids and the very essence of life, making sure we cover every topic, every concept in detail so you really can achieve that mastery.
Okay, so let's begin by laying the groundwork. How blood actually moves through our system. This is the realm of hemodynamics. And it all starts, I think, with clarifying two fundamental terms that often get confused.
You're right to highlight that. First, let's be clear. Velocity measures speed. It's the distance a particle of fluid travels over time, like, say, centimeters per second. Flow, on the other hand, measures volume. It's the rate at which a volume of fluid is displaced, typically expressed in cubic centimeters per second. Now, in a simplified rigid tube, if the flow volume is constant, velocity and the cross-sectional area of the tube are inversely related. This means the fluid moves fastest where the tube is narrowest. Pretty straightforward there.
And how does that principle translate to our blood vessels? Because they're certainly not rigid pipes, right? They have varying widths.
It's fascinating how it applies. In your body, blood velocity progressively decreases as it moves through the arterial system. It reaches its absolute minimum in the capillaries.
Huh. Which seems counterintuitive because capillaries are so tiny.
Exactly. That's what most people think. But the key is their total cross-sectional area. When you add up the cross-sectional area of all the millions and millions of capillaries in parallel, that cumulative area is just immense, far larger than, say, the aorta. This vast collective area is precisely why the blood flow slows down so dramatically. It gives time for exchange. Then, as blood makes its way back through the venous system, that total cross-sectional area progressively narrows again, and velocity increases as the blood approaches the heart. It's really a brilliant design.
That makes perfect sense. So as blood changes its speed, how does that velocity impact the pressure inside the vessel? This is where it starts to get really interesting, I think.
Right. The total hydraulic energy within your circulatory system has three main components: static pressure, the influence of gravity, and the energy associated with velocity. Now, there's this dynamic component of pressure, Platon, often estimated by the formula ρ2, where ρ is fluid density and v is velocity. In most large arteries, this Platon is usually negligible, really tiny,
Right.
but it becomes critically important at sites of arterial constriction. Think about a partial blockage, maybe from atherosclerosis or a spasm.
Like a narrowing.
Exactly. At that constricted point, blood flow velocity skyrockets. Has to get the same volume through. This sudden increase in velocity leads to a significant rise in dynamic pressure, but paradoxically, it causes a reduction in the lateral pressure exerted on the vessel wall.
So less pressure pushing outwards.
Yes. And the real-world implication here, this drop in lateral pressure can actually decrease blood flow downstream from the constriction, meaning less blood reaches the tissues that need it. It creates a real challenge for the body. And this phenomenon immediately raises a critical question. How does your body, with all its intricate controls, manage to compensate for such local changes to ensure that vital tissues still receive adequate blood supply?
That's a perfect lead into Poiseuille's law. It's a classic in fluid dynamics, originally applied to steady, smooth, or laminar flow of simple fluids through rigid tubes. Now, we know blood is a bit more complex, and our vessels are definitely not rigid, but this law still offers invaluable insights, right, into the fundamental mechanics.
Absolutely. It's foundational. To truly grasp Poiseuille's law, we first need to clarify a few concepts. A Newtonian fluid is one whose viscosity, its thickness, stays constant regardless of how fast it's flowing or being sheared. Blood isn't perfectly Newtonian, but we often approximate it as such for this law. And laminar flow, that's the smooth, orderly movement. Think of fluid particles gliding past each other in parallel layers, like infinitesimally thin tubes sliding one inside another. The layer in the very center moves fastest, and the layers closer to the vessel wall move slower, creating a kind of a parabolic profile. No chaotic mixing, no swirling. It's efficient.
Got it. Smooth layers.
So Poiseuille's equation lays out how these factors interact. It says that the flow volume, Q, through a tube is directly proportional to the pressure difference, the gradient from inlet to outlet. Makes sense. More push means more flow. And here's the absolute game changer. Flow is also directly proportional to the fourth power of the tube's radius, r to the power of 4.
The fourth power. That sounds dramatic.
It is. Conversely, flow decreases if the fluid viscosity increases or if the tube length increases. But that fourth power relationship with the radius is the standout. Think of it this way. If you were to just halve the radius of a blood vessel, you wouldn't just halve the flow. You'd actually decrease it by a factor of 16.
Wow, 16 times less flow just from having the width.
Exactly. That's the real aha moment here. Even tiny changes in vessel width, which smooth muscle can achieve, have these colossal impacts on blood flow. It's the body's main control mechanism.
Okay, so that explains resistance.
Precisely. If we think of hydraulic resistance as simply the pressure drop across a vessel divided by the flow through it, very similar to Ohm's law in electronics, R equals E over I.
Right, voltage over current.
Yeah. So here it's pressure drop over flow, R epi Q. Poiseuille's law reveals the physical bits that make up that resistance. The formula, R, IMPL, R4, shows resistance is proportional to viscosity and length L, but inversely proportional to, again, that critical fourth power of the radius. It just keeps coming back to radius, doesn't it?
It really does. Vessel caliber is king.
It is. Changes in vascular resistance are mostly driven by changes in the caliber of vessels, especially those arterioles with lots of smooth muscle. They contract or relax to tweak the lumen size. External pressure also matters. The greater the transmural pressure, that's the difference between inside pressure pushing out and outside pressure pushing in, the more an elastic vessel distends, and the less its hydraulic resistance.
Like blowing up a balloon makes the opening wider.
Kind of, yeah. It reduces the resistance to flow.
So, considering this immense power of radius, which vessels in the body actually have the highest resistance and why? It seems like it should be the capillaries.
That's a great question, and it's a bit paradoxical. While the single biggest drop in pressure happens across the small arteries and arterioles, making them the primary resistance vessels for the whole system,
Okay.
individual capillaries with their incredibly tiny average diameter, maybe 7 micrometers, actually have the greatest resistance per unit length.
Per unit length. That's the key.
Right. But when we talk about the total resistance in the systemic circulation, it's the arterioles, not the capillaries, that contribute the most. Why? Because there are just vastly more capillaries arranged in parallel than there are arterioles. So that massive parallel network spreads the resistance out.
Like multiple checkouts opening at the supermarket.
Exactly. Plus, arterioles have those thick, muscular walls, allowing for really significant changes in their radius. They can fine-tune resistance using that powerful fourth power relationship.
Okay, that makes sense. And how does this series versus parallel arrangement work for the whole system?
Right. So resistances can be arranged in series or in parallel. For vessels in series, think of the path blood takes. Artery, then arterial, then capillary, then venule, then venal. The total resistance is simply the sum of the individual resistances. R total, R1 plus R2 plus R3. Easy enough.
Just add them up.
Just add them up. But for vessels arranged in parallel, like all the capillary beds within your kidney or all the different organs supplied by the aorta, the calculation is different. Here, the reciprocal of the total resistance equals the sum of the reciprocals of the individual resistances. So 1 R total equals 1 R1 plus 1 R2 plus 1 R3.
A bit more complex math.
A bit. But the really important consequence is this. The total resistance of a parallel network is always less than the resistance of any single component within it.
Always less.
It's like having multiple routes to get somewhere. The overall capacity is greater than any single road. And to put some numbers on this for you, the total peripheral resistance, TPR, for your entire systemic circulation, let's say arterial pressure, is 100 millimillion Hg, venous is 0, cardiac output is 5 liters per minute. The TPR is incredibly low, around 0.02 peripheral resistance units, or PRUs. Tiny. Now, compare that to the resistance of just one organ, like your kidney. It might have a resistance around 0.17 PRUs. That's, what, 8.5 times greater than the TPR of your whole body? If we connect this to the bigger picture, it just beautifully illustrates how the body's entire circulatory system is designed for overall efficiency. It uses this massive network of parallel pathways to keep the total resistance low, even though individual organ beds can crank up their own resistance quite high to control their specific blood flow needs. It's a remarkable piece of natural engineering.
It really is. That's a profound illustration of efficiency. Okay, building on this, let's explore the two distinct types of blood flow we mentioned, laminar and turbulent, and what they mean for the heart's work and, overall health.
Right. We've established laminar flow as that smooth, orderly, efficient state. Turbulent flow is the opposite, irregular, chaotic, lots of radial mixing, swirling eddies, vortices. It's messy.
Like rapids in a river versus a smooth stream.
Good analogy. And when blood flow becomes turbulent, your heart has to work significantly harder. It needs greater pressure to push the same volume of blood through the same vessel compared to when flow is laminar. Whether flow stays laminar or becomes turbulent can be predicted by a value called the Reynolds number, NR. The formula involves density, diameter, velocity, and viscosity.
Okay, the details aren't crucial now.
Right. The key takeaway is that high velocity, large vessel diameter, or low blood viscosity, like you see in anemia, all push things towards turbulence. Generally, an NR below 2,000 is laminar, above 3,000 is turbulent, and in between is transitional.
And how does this show up clinically?
Well, turbulent flow creates vibrations we can actually hear. So when a doctor listens with a stethoscope and hears a murmur in the heart, that's usually turbulence, maybe from a faulty valve or flow through a narrow opening. Similarly, a bruit, that whooshing sound over a blood vessel, indicates turbulence there, perhaps due to plaque buildup, a stenosis. A common example is severe anemia. Blood viscosity is low, and the heart often beats faster, increasing flow velocity. This combination frequently causes functional murmurs, even if the heart structure is normal. And here's a critical point. Blood clots, thrombi, are far more likely to form in turbulent flow than in smooth laminar flow.
That sounds dangerous.
It is. It's a major challenge for things like artificial heart valves. Engineers have to design them very carefully to minimize turbulence, and patients usually need anticoagulants, blood thinners, to prevent dangerous clots from forming on or near the valve.
Right, so beyond the flow pattern, you also mentioned shear stress. What's that?
Shear stress is the force exerted by the flowing blood parallel to the vessel wall. It's like friction dragging along the endothelium. It's directly proportional to the flow rate and the blood's viscosity. Higher flow, higher viscosity means more shear stress.
Is this clinically significant?
Oh, definitely. In certain arterial diseases, especially with chronic hypertension, the layers beneath the endothelium can weaken. High shear stress, particularly in places like the aorta where velocity is high, can contribute to a tear in that inner lining. If that happens, blood can force its way between the layers of the arterial wall, splitting them apart. That's a dissecting aneurysm. Extremely serious, life-threatening.
Wow.
Shear stress also influences a lot of other things. How permeable the vessel walls are, the biochemical activity of those endothelial cells, blood coagulation. And interestingly, an increase in shear stress is a powerful trigger for the endothelial cells to release nitric oxide, NO, which is a potent vasodilator. So the flow itself can influence vessel tone.
That's a fascinating link between pure mechanics and the biology. Okay, now let's turn our attention from the tubes themselves to the fluid flowing inside them.
Yeah.
Because as you said, blood is way more complex than just water. Let's unpack the unique properties of blood, its rheology.
Absolutely. Blood isn't simple. When we talk about its viscosity, we often use the term apparent viscosity. That's because blood is a suspension. It's formed elements, mostly red blood cells, erythrocytes, floating in plasma. The biggest factor determining this apparent viscosity is the hematocrit, the percentage of your blood volume that's made up of red blood cells.
Right, the packed cell volume.
Exactly. As hematocrit goes up, apparent viscosity increases, and it gets particularly steep at really high concentrations. Just for context, plasma itself is already about 1.2 to 1.3 times more viscous than plain water. So if you have severe anemia, low hematocrit means low blood viscosity.
Okay, so concentration matters a lot. Now, I've heard something surprising, that blood's apparent viscosity actually decreases as the tube it's flowing through gets smaller, specifically below about 0.3 millimeters. How does that work? That seems backwards.
It does seem backwards. That's the Farese-Lindquist effect. It's a really clever adaptation, actually. Part of the reason is how blood components arrange themselves in these tiny tubes. The red cells, being bigger and denser, tend to congregate in the faster central part of the stream, the axial stream. Meanwhile, the plasma flows more in the slower layers near the vessel wall.
Ah, so the cells take the fast lane.
Pretty much. And because the cells are in the faster stream, they actually travel through the tube quicker than the average plasma molecule. What's more, the actual hematocrit inside these very small vessels is lower than the hematocrit in your larger arteries or veins. This whole phenomenon is super important because it reduces the resistance to flow precisely in those small vessels, like arterioles, which are the main resistance controllers. It helps blood flow through the microcirculation more easily.
That's incredibly clever, almost like self-lubricating.
In a way, yes. Another fascinating property is shear thinning. Blood's apparent viscosity diminishes as the shear rate, or basically the flow rate, increases.
So the faster it flows, the thinner it seems.
Exactly why. Well, at higher flow rates, red cells tend to aggregate less. At very slow flow rates, they can clump together in stacks, like coins called rouleaux, which increases viscosity.
Rouleau, right.
But as flow speeds up, these aggregates break apart and the cells tend to line up more efficiently in those fast axial layers we mentioned. So apparent viscosity drops. Plasma proteins like fibrinogen also influence this aggregation.
Okay.
And erythrocyte deformability is another huge factor, especially at high hematocrit. Your red blood cells are about 7 micrometers across, but they can remarkably squeeze through capillaries as narrow as 3 micrometers.
Amazing flexibility.
It is. And as flow rate increases, these cells get deformed more, almost stretched out. This deformation actually reduces the apparent viscosity. Fibrinogen, interestingly, seems to enhance this flexibility. Conversely, if red cells become hardened, like in sickle cell anemia, the shear thinning ability is impaired. And one more point, at very low flow rates, white blood cells, leukocytes, can actually stick to the endothelium of microvessels, which can temporarily increase apparent viscosity locally. So you put all this together, the Fourier-Lindquist effect, shear thinning, deformability. It makes you wonder, how do all these intricate blood properties work together to ensure efficient circulation, especially down in those tiny, tiny vessels?
That's a perfect lead-in to the arterial system. We often picture arteries as just passive pipes carrying blood away from the heart. But you're saying they're much more dynamic, elastic, almost like active partners in the whole process. Let's explore how the arterial system really works.
They are absolutely active partners. The large arteries, think aorta, pulmonary artery, are remarkably distensible, very stretchy, thanks to lots of elastin in their walls. This stretchiness lets them act as a crucial storage system, a sort of hydraulic accumulator.
Storage, how so?
During systole, when your heart forcefully ejects blood, these elastic arteries stretch and expand, absorbing a lot of that pulsatile energy and volume. Then, during diastole, when the heart relaxes and fills, the stretched arterial walls recoil elastically, like a released rubber band. This recoil keeps pushing the blood forward smoothly. This Windkessel effect, as it's sometimes called, is critical. It dampens the heart's naturally jerky pulsatile output and transforms it into a much steadier, more continuous flow by the time blood reaches the delicate capillaries. That steady flow is essential for efficient nutrient and waste exchange in your tissues.
Okay, so it smooths out the pulses.
Exactly. And this elasticity also significantly reduces the heart's workload. Imagine if your arteries were rigid tubes, like lead pipes.
Yeah, the pressure would spike really high with each beat.
Dramatically high. The heart would have to pump against a much higher afterload, the resistance it faces ejecting blood. This would take way more energy. But by distending, these elastic arteries prevent those huge pressure spikes. However, as we age, arterial compliance, that stretchiness, naturally decreases. The arteries get stiffer.
Right, hardening of the arteries.
Essentially. And this leads to an increase in systolic blood pressure and, importantly, an increase in pulse pressure, the difference between systolic and diastolic.
Let's quickly clarify those different pressures again for everyone listening.
Yeah.
Mean arterial pressure, systolic, diastolic, and that pulse pressure.
Good idea. Mean arterial pressure, or MAP, is the average pressure over a whole cardiac cycle. Systolic pressure, or RSS, is the peak pressure during heart contraction or ejection. Diastolic pressure, PRS, is the lowest pressure when the heart relaxes. And pulse pressure is simply systolic minus diastolic, PSPD. Now, what determines your arterial blood pressure? We can group the factors into physical and physiological. Physical factors are basically the volume of blood within the arterial system and the arterial compliance, how stretchy the arteries are. Physiological factors are your cardiac output, which is heart rate times stroke volume, the amount pumped per beat, and your total peripheral resistance, TPR, the overall resistance the blood encounters flowing out to the tissues.
Right.
We can approximate mean arterial pressure, MAP, using the measured systolic and diastolic with a common formula. MAP is roughly systolic plus 2 times diastolic divided by 3.
Why weighted towards diastolic?
Because diastole usually lasts longer than systole in the cardiac cycle, so the average pressure is closer to diastolic. MAP fundamentally depends on the volume of blood in the arteries and their compliance. If cardiac output goes up or TPR goes up, MAP will rise. If either falls, MAP falls. Simple relationship there.
Got it. And what about pulse pressure specifically?
Arterial pulse pressure, that difference between the peak and trough, is mainly a function of 2 things: your heart stroke volume and arterial compliance. A larger stroke volume, more blood pumped per beat, stretches the arteries more, increasing pulse pressure.
Right.
And as we said, reduced arterial compliance, stiffer arteries, also increases pulse pressure for a given stroke volume. This stiffness also adds a greater workload, a higher afterload for your left ventricle. It's also worth noting that arterial compliance isn't fixed. It actually decreases as mean arterial pressure itself goes up. So as MAP rises, pulse pressure tends to rise disproportionately. It's not a linear relationship.
That link between compliance and the heart's energy use sounds really important.
It's incredibly significant. A rigid arterial system dramatically increases how much energy your heart needs. Experiments have vividly shown this. If you measure myocardial oxygen consumption, how much oxygen the heart muscle uses, it's substantially greater when blood is pumped through a stiff tube compared to the natural elastic aorta, even if the cardiac output and TPR are identical. It tells us your left ventricle expends significantly more energy just to overcome the stiffness of the conduit. Compliance saves energy.
Okay, and clinically, what can pulse pressure tell us?
Well, assuming arterial compliance is reasonably normal, pulse pressure gives us valuable clues about stroke volume. For instance, patients with severe congestive heart failure or who've had a major hemorrhage often have a very low or narrow pulse pressure because their stroke volumes are tiny.
Makes sense.
On the flip side, people with large stroke volumes may be due to aortic valve regurgitation where blood leaks back, or even very fit athletes at rest who have slow heart rates and long filling times. They tend to have an increased or wide pulse pressure. It's a useful, non-invasive indicator.
Okay, and what about that pulse wave itself? You said it travels faster than the blood.
Yes, much faster. When your heart ejects blood, it creates this pressure wave that travels down your aorta and its branches at incredible speeds, typically 4 to 12 meters per second. That's what you feel as a pulse at your wrist or neck.
Much faster than blood flow itself.
Oh, yeah. And as this pressure wave travels, its shapes actually distorts and can even amplify, peaking higher in more peripheral arteries than in the aorta itself. This is due to a complex mix of factors: the viscoelastic properties of the artery walls, reflections of the wave bouncing back from branch points and peripheral resistance vessels, the tapering of vessels, and even pressure-induced changes in wave velocity. In older individuals, though, because their arteries are stiffer, less compliant, this pressure wave travels even faster, and there's less dampening or amplification as it moves peripherally.
How does this tie into hypertension?
It's highly relevant. In chronic hypertension, where TPR is persistently high, the arteries become significantly less compliant as the mean arterial pressure rises. This leads to that disproportionate increase in systolic pressure compared to diastolic pressure we talked about. So while diastolic might be up by, say, 10 to 40 mmHg, it's common to see systolic pressure shoot up by 50 to 100 mmHg above the normal 120. It's a hallmark of age-related arterial stiffening combined with hypertension.
Okay, so with all this vital information packed into blood pressure, how do we actually measure it in practice?
Well, the most common way, the one you see in the doctor's office, is the indirect method using a sphygmomanometer, the inflatable cuff and pressure gauge.
Right, the cuff method.
For the absolute most precise readings, especially in, say, intensive care, you can use direct arterial catheterization, placing a small sensor directly inside an artery. But that's invasive. The standard cuff method, the auscultatory method, uses a stethoscope to listen over the brachial artery in your arm. Here's how it works. First, inflate the cuff well above the expected systolic pressure. This completely closes off the artery. No blood flows, so you hear no sounds through the stethoscope. Silence. Then you slowly deflate the cuff. The moment the cuff pressure drops just below the peak systolic pressure, tiny spurts of blood manage to force their way through the compressed artery with each heartbeat. These spurts hit the stationary column of blood downstream, creating turbulence and distinct tapping sounds, the cough sounds. The pressure reading when you first hear these sounds is your systolic pressure.
Okay, the first tap.
Right. As you continue to deflate the cuff, the sounds often change in quality, maybe becoming more muffled. Then, when the cuff pressure falls just below the diastolic pressure, the artery is no longer constricted during any part of the cardiac cycle. Blood flow becomes smooth and continuous, again laminar, and the sounds disappear completely. The pressure reading at the point the sounds vanish is your diastolic pressure.
Sound's gone, that's diastolic. Simple enough.
The sounds themselves are basically caused by that turbulent flow generated by the intermittent spurts meeting static blood. Once flow is smooth, the turbulence, and thus the sound, stops.
You also mentioned something called the ankle brachial index.
Yes, the ABI. It's a really simple but remarkably powerful diagnostic tool. You calculate it by dividing the systolic blood pressure measured at the ankle, usually from the dorsalis pedis artery on top of the foot, by the systolic pressure measured in the brachial artery of the arm.
Ankle pressure over arm pressure.
Exactly. The ABI is an excellent indicator for peripheral artery disease, PAD, blockages in the leg arteries, but it's also recognized as a strong predictor for future cardiovascular and cerebrovascular risk heart attacks and strokes. A normal ABI ratio is typically between 1.1 and 1.4. People in this range generally have a lower risk of major cardiovascular events compared to those with an ABI of 0.9 or lower, which suggests PA. And if someone's ABI ratio significantly decreases over time, that correlates with an increased risk of cardiovascular problems and mortality. It's a simple, non-invasive test with really big implications for risk assessment.
Fascinating. Okay, let's shift our focus now to the venous system. This is the return trip for blood. Often seems less dramatic than the arteries, but you said it's incredibly vital. So what makes the venous system so critical?
The venous system has this absolutely essential dual function. First, yes, obviously veins return blood from your tissues back to the heart. But equally important, they act as a massive compliant reservoir. They hold a huge proportion, sometimes up to 70% of your body's total blood volume at any given time.
70%, that's huge.
It is. This high capacitance, this ability to hold a lot of volume without a big pressure increase, allows the venous system to adjust the volume of blood returning to the heart, what we call preload, to match your body's changing needs. It helps balance cardiac output.
So it buffers volume change.
Precisely. Veins also have very low resistance to blood flow. This lets blood move smoothly all the way from the tiny postcapillary venules, where pressure might be around 20 mmHg, back to the big vena cava and right atrium, where pressure is near zero. That's your central venous pressure, CVP, with only very small pressure drops along the way. Venous compliance, their stretchiness, isn't uniform. Veins in your legs, for example, are less compliant. They have thicker walls compared to veins in, say, your abdomen or arms. And just like arteries, venous compliance tends to decrease with age, mostly due to changes in elastin and collagen. Adjustments in venomotor tone, how constricted or relaxed the smooth muscle in the vein walls is, along with your breathing activity and the effects of gravity when you stand up, all work together to fine-tune venous return.
Okay, let's dig into that gravity point. It seems like standing up would just make all the blood pool in your legs. How does the body handle that? This seems really ingenious.
Gravity absolutely does cause blood to pool independent vessels, especially when you stand upright. For instance, when an average adult goes from lying down to just standing relaxed, somewhere between 300 and 800 milliliters of blood can shift and accumulate in the legs.
Wow, nearly a liter sometimes.
Yeah, it's significant. This pooling distends both arteries and veins down there, but because veins are so much more compliant, so much stretchier than arteries, most of that volume pools on the venous side. This venous pooling reduces the amount of blood returning to your heart, which can dramatically drop your cardiac output.
Is that why people faint if they stand still too long?
Exactly, like soldiers standing at attention. Or why pilots can black out during high-G maneuvers. The forces cause massive pooling away from the head. But your body has evolved really sophisticated compensatory adjustments to fight this. Similar to how it responds to bleeding, actually. These include reflex increases in your heart rate and how forcefully your heart contracts. Plus, both arterioles and veins constrict reflexively, although the arterioles usually constrict more strongly. These adaptations help maintain blood pressure and keep blood flowing to vital organs despite gravity's pull.
And what about the muscle pump? I hear about that.
Yes. The skeletal muscle pump is one of the most effective auxiliary pumps for venous return, and it works hand in hand with the one-way valves inside your veins. When you stand quietly, venous pressure in your legs does rise, but relatively slowly because these valves break up the long column of blood into shorter segments, supporting the weight.
Like locks in a canal.
Good analogy. But when you start using your leg muscles walking, running the contractions squeeze the deep veins embedded within those muscles. Because the valves only allow blood to flow towards the heart, this intermittent compression effectively milks the blood upwards against gravity. This muscle pump is incredibly effective. It prevents excessive venous pooling, lowers the average venous pressure in your leg significantly, and reduces the tendency for fluid to leak out into the tissues and cause edema or swelling in your feet and ankles.
So movement is key.
Absolutely. Movement keeps that pump working.
And what happens when these systems fail? What do we see clinically?
We see the consequences frequently. Orthostatic hypotension, that's a significant drop in blood pressure when you stand up, can happen if these reflex adaptations are impaired. Maybe by certain medications, autonomic nervous system problems, or even after prolonged weightlessness like astronauts experience.
Yeah.
Another clinical sign is cervical venous distension. If you see the superficial veins in someone's neck bulging out even when they're sitting or standing upright, that's a sign of elevated central venous pressure, often pointing towards congestive heart failure.
Oh, okay.
And of course, varicose veins. In this condition, the one-way valves are leaky or incompetent. This makes the muscle pump much less effective. Blood pools, venous pressure in the ankles and feet gets excessively high, especially during standing, and this pushes fluid out into the tissues, causing chronic edema and those visible, tortuous veins.
So we've journeyed through the big supply pipes, the reservoir, and return lines. Now let's zoom way in to the real business end of circulation, the microcirculation, these tiny vessels where all the vital exchange happens. Let's unpack this crucial hub.
The microcirculation is indeed the dynamic interface. We're talking about blood flow through the smallest vessels, the arterials, capillaries, and venules. Arterioles, maybe 5 to 100 micrometers wide, are highly muscular. They're your main resistance vessels, the gatekeepers controlling flow into the capillary beds downstream. They can branch directly into capillaries or sometimes into slightly larger vessels called metarterioles, around 10 to 20 micrometers.
Metarterioles. What's special about them?
They're interesting because they can act as thoroughfare channels. They have rings of smooth muscle, pre-capillary sphincters at their origin, and where true capillaries branch off. If these sphincters close off the capillary entrances, blood can flow directly through the metarteriole into a venule, essentially bypassing the exchange network. This allows for non-nutritional or shunt flow, diverting blood when needed.
Okay, so it can bypass the main exchange area.
Right. Capillaries themselves are incredibly thin-walled, just 5 to 10 micrometers in diameter, forming this vast interconnected network designed purely for exchange. You find really high capillary density in metabolically active organs, heart, skeletal muscle, brain, and lower density, where metabolic needs are less, like cartilage. Some capillaries are actually narrower than your red blood cells, which forces those amazingly flexible erythrocytes to deform, to squeeze through single file. Blood flow within the capillaries is largely dictated by the contractile state of the upstream arterioles and those precapillary sphincters. And within these precapillary vessels, we see something called vasomotion, a slow, rhythmic opening and closing, contraction and relaxation. It seems to be an intrinsic behavior of the vascular smooth muscle, influenced by the pressure inside the vessel. But crucially, this intrinsic rhythm can be overridden by the local metabolic needs of the tissue. If oxygen gets low, for example, the vessels tend to relax and stay open longer. And while true capillaries lack smooth muscle, their endothelial cells, that single layer forming the wall, can subtly change shape in response to certain chemicals, which might influence flow locally.
That's remarkable detail. But you mentioned the thin walls. How do these incredibly fragile-looking capillaries, often just one cell thick, manage to withstand relatively high pressures without just bursting? It seems like they'd be incredibly weak.
That's where the elegance of physics comes in again, specifically the law of Laplace. The law of Laplace relates the tension, T, in the vessel wall, the force holding it together against the internal pressure to the transmural pressure, P, and the radius R of the vessel. The basic equation is T equal P times R.
Tension equals pressure times radius.
Right. Now, for capillaries, the absolute key is their exceptionally small radius. Because R is so tiny, even if the pressure P inside is reasonably high, the resulting wall tension T needed to contain that pressure is remarkably low.
Oh, because the radius term is so small.
Exactly. To put it in perspective, at normal pressures, the wall tension in your aorta is something like 12,000 times greater than the tension in a capillary wall. Even if capillary pressure in your feet gets up to 100 mmHg when you're standing, the wall tension required is still minuscule compared to the aorta. It's a beautiful example of scaling in biology. Small size confers strength against pressure.
That explains a lot. What about clinically? Does Laplace's law apply elsewhere?
Oh, yes. It helps us understand, for example, why a heart that becomes greatly dilated, enlarged, as often happens in heart failure, functions less efficiently. A larger radius means that for the same internal pressure, the heart muscle has to generate significantly more wall tension to eject blood. It has to work harder just because it's bigger. This increases its energy demand and makes pumping less efficient.
Makes sense. You also mentioned critical closing pressure.
Right. Critical closing pressure is the theoretical pressure point at which blood flow through an arterial completely stops. It happens when the active contractile force of the smooth muscle cells in the arterial wall becomes strong enough to overcome the outward pushing pressure of the blood inside, effectively squeezing the vessel shut. This pressure isn't fixed. It's lower when sympathetic nerve activity to the vessel is low, causing relaxation, and higher when sympathetic tone is high, causing constriction. It's another control point for shutting down flow if necessary.
Okay, a clever mechanism. Now, building on this, let's explore something truly amazing. You said the capillary endothelium, that single-cell layer lining the vessels, isn't just a passive barrier. These cells are like miniature pharmacies, actively producing substances that control blood flow and vessel health. This is where it gets really interesting at the cellular level, right?
You've absolutely hit on a crucial point. The endothelium is far from passive. It's a highly active, dynamic organ, really, producing powerful vasoactive substances. One key player is prostacyclin, or PGI2. It's made by endothelial cells from arachidonic acid. Its main jobs are to relax the vascular smooth muscle downstream, causing vasodilation, and very importantly, it inhibits platelets from sticking and clumping together, helping to prevent clots inside the vessels. It's often released when shear stress increases.
So it keeps things flowing smoothly.
Exactly. Even more pivotal, perhaps, is the formation and release of nitric oxide, NO. NO is a major endothelium-derived relaxing factor, or EDRF. When endothelial cells get stimulated by various signals, things like acetylcholine, ATP, bradykinin, serotonin, histamine, or even just increased shear stress, they ramp up production of NO from the amino acid L-arginine. This NO then diffuses to the nearby smooth muscle cells and activates an enzyme called guanine cyclase. This boosts levels of cyclic GMP, or cGMP, which triggers a cascade leading to smooth muscle relaxation and vasodilation. It's a fundamental mechanism for flow control.
A tiny gas molecule doing all that.
It's amazing. And there are other direct vasodilators, too, often released from the surrounding tissue cells themselves when they get active or stressed, things like adenosine, hydrogen ions from acidity, CO2, potassium ions. They all act locally on these resistance vessels.
Okay, how does this relate to things like atherosclerosis?
Great question. We now know that endothelial injury or dysfunction is a key early step in the development of atherosclerosis, the hardening and clogging of arteries. A healthy endothelium, largely through its ability to produce NO, has a protective or antiatherogenic effect. NO helps regulate white blood cell adhesion to the vessel wall, reducing inflammation. It suppresses the abnormal growth of vascular smooth muscle cells, which contributes to plaque buildup. It helps maintain the lining's resistance to thrombus formation, and of course, it regulates vascular tone. NO is really a guardian of arterial health.
So endothelial health is paramount.
Absolutely. Conversely, the endothelium can also synthesize endothelin, which is one of the most potent vasoconstrictor peptides known. Endothelin plays a role in regulating vascular tone and blood pressure, but it's also implicated in various disease states, including atherosclerosis, pulmonary hypertension, heart failure, and kidney failure. So the endothelium can swing both ways, relax or constrict.
A powerful controller. Okay, so we've covered the active pharmacy-like role. Now let's shift to how stuff actually moves across the capillary walls, the passive but equally vital exchange process.
Right. How do nutrients get out and waste products get in? Fluid and solutes move across the capillary endothelium mainly by three routes: diffusion, filtration, and a bit of penocytosis. By far, diffusion is the most important process for the actual exchange of solutes. Filtration deals more with fluid balance. Just to give you a sense of scale, under normal conditions, maybe 300 milliliters of water per minute move across the capillary walls and 100 grams of tissue just by diffusion, compared to only about 0.06 millirad by filtration. Diffusion dominates solute exchange.
Huge difference.
It's central for gases like O2 and CO2, metabolic fuels like glucose, and waste products like urea moving between your blood and tissue cells. Diffusion follows Fick's law, which basically says the rate of movement is proportional to the permeability of the capillary to that substance, the total surface area available for diffusion, and the concentration difference across the wall. We often combine permeability and surface area into the PS product. It
Bottom.
represents the overall diffusion capacity. Normally, the intrinsic permeability of capillaries doesn't change much physiologically, but it can increase dramatically in pathology, like with inflammation or a bee sting, making them leaky.
Okay, and does it differ for different types of molecules?
Yes, very much so. For small lipid-insoluble molecules, things like water itself, glucose, sodium chloride, urea diffusion is mostly restricted to tiny water-filled pores or clefts between or perhaps through the endothelial cells. Their movement across the wall is usually so rapid that the main thing limiting their net transfer is simply how fast blood flow delivers them to the capillary in the first place. We call this flow-limited transport. More flow, more delivery, more diffusion.
Delivery rate is the bottleneck.
Exactly. Now, for large lipid-insoluble molecules like plasma proteins, think albumin, anything over maybe 60,000 Daltons, they're generally too big to fit through those small pores easily. For these molecules, the capillary's low permeability itself becomes the limiting factor. This is diffusion-limited transport. It can also apply to small molecules if diffusion distances get really large, like in swollen tissue, edema, or if capillary density is very low.
Okay, what about gases like oxygen?
Ugh. Lipid-soluble molecules like oxygen and carbon dioxide are different again. They don't need pores. They can dissolve in and pass directly through the lipid cell membranes of the entire capillary endothelium. This makes their movement incredibly rapid. The ease of transfer correlates directly with how lipid-soluble they are. And here's a crucial point. Oxygen supply to your normal tissues, both at rest and during moderate activity, is generally not diffusion-limited. It's flow-limited.
Flow limited again.
Meaning your tissues are usually very efficient at extracting the oxygen delivered. If blood flow decreases, oxygen delivery decreases proportionally because diffusion across the capillary wall isn't the bottleneck, the delivery rate is. We also know that gas exchange for O2 and CO2 actually starts even before the capillaries in the small arterioles and precapillary vessels.
Fascinating. Okay, that's diffusion. What about filtration?
Capillary filtration deals with the bulk movement of water across the capillary wall. Most of this water moves through those small pores and intercellular clefts, maybe 4 nanometers wide in typical muscle capillaries. But permeability varies. Liver capillaries are very leaky, muscle less so, and cerebral capillaries, forming the blood-brain barrier, essentially lack these pores altogether. Some specialized capillaries, like in your kidneys, glomeruli, or intestines, have fenestrations, small windows or pores that allow much faster fluid movement. Liver sinusoids have even larger gaps, a discontinuous endothelium, letting big molecules like proteins pass easily. Permeability can even vary along a single capillary, often being higher at the venous end.
So what drives this water movement, this filtration?
It's governed by a balance of pressures, hydrostatic pressures pushing fluid out, and osmotic pressures pulling fluid in. This is famously known as Starling's hypothesis, or the Starling forces. Filtration fluid moving out of the capillary into the interstitial space happens when the sum of these forces pushes outwards, positive net pressure. Absorption fluid moving back into the capillary happens when the sum pulls inwards, a negative net pressure.
Okay, let's break down those forces. Hydrostatic first.
Right, hydrostatic forces. The main one is the capillary hydrostatic pressure, PC, essentially the blood pressure inside the capillary. It drops along the capillary length. Typical average values might be around 32 millimol Hg at the arterial end and 15 millimol Hg at the venous end in skin capillaries at heart level. Changes in arterial or venous pressure affect PSC, but importantly, changes in venous pressure have a proportionally greater effect on capillary pressure than arterial changes do. Opposing this outward push is the interstitial fluid hydrostatic pressure, capillary, the pressure in the fluids surrounding the capillaries. It's normally very close to zero, maybe slightly negative.
Okay, push out from blood pressure, slight push back from tissue fluid. Now osmotic.
Yes, the osmotic forces. The primary force pulling water back into the capillaries is the osmotic pressure created by the plasma proteins, mainly albumin, which are too large to easily escape. This is called colloid osmotic pressure, or oncotic pressure, and it's typically around 25 millimol Hg.
So the proteins inside act like sponges for water.
Exactly. Albumin is key. Not just its concentration, but also its negative charge attracts positive ions, like sodium, the Gibbs-Donner effect, which adds slightly to its osmotic pull. We also need to consider the reflection coefficient, which describes how effectively the capillary wall prevents a solute from passing. Water passes freely, while albumin is largely retained, CLO. There's also usually a small amount of protein that leaks into the interstitial fluid, creating a slight interstitial fluid oncotic pressure, pulling water out, but it's generally much smaller than the plasma oncotic pressure.
Okay, so PSC pushes out, P pulls in, pi pushes in or is near zero, I pulls out but is small.
You got it. The net movement depends on the balance of PC pi versus SPIPE.
And how does this play out along the capillary?
Well, the classic view is that at the arterial end, where PC is high, say 32 mmHg, the outward hydrostatic forces dominate the inward oncotic forces, so you get net filtration. As blood flows along, PC drops to maybe 15 mmHg at the venous end. Now, the inward oncotic pressure, still around 25 mmHg, dominates, and you get net absorption. So fluid filters out at the start, and most of it gets reabsorbed at the end. That's the traditional model.
Mostly balanced.
In a healthy state, yes. Although some recent research suggests filtration might occur along more the capillary length than previously thought, with the lymphatic system picking up the excess. It also depends on the specific vascular bed. Renal glomeruli filter along their entire length. Intestinal mucosa primarily absorbs. And things like arteriolar vasoconstriction can temporarily lower PC enough to cause net absorption even at the arteriolar end.
How does this relate to edema, swelling?
Directly. If filtration significantly exceeds absorption and lymphatic drainage, fluid accumulates in the interstitial space that's edema. For example, prolonged standing increases venous pressure in the legs, which increases PAC, enhancing filtration. If it overwhelms lymphatics, your ankles swell. Similarly, if you lose plasma proteins, maybe due to kidney disease or severe malnutrition, your plasma oncotic pressure drops. The force holding fluid in the capillaries weakens, leading to edema. Or in left heart failure, pressure backs up into the lungs, raising pulmonary capillary hydrostatic pressure, PC. If PC exceeds PAC, fluid floods the lung interstitium, pulmonary edema. Very dangerous.
So Starling's forces are critical in these conditions. What's the capillary filtration coefficient?
The capillary filtration coefficient, NAT, is basically a measure of how easily fluid can move across the capillary wall. It represents both the intrinsic permeability of the capillary wall and the total surface area available for filtration. Normally, it's fairly constant for a given tissue, but it increases significantly if capillaries are injured, say by toxins or burns, making them leaky. Physiologically, NAT can increase if more capillaries open up. During exercise, for instance, metabolic vasodilation in muscles opens more capillaries, increasing the total surface area and thus NAT, allowing more exchange and fluid filtration.
Okay. And does the body compensate for changes in these forces?
Oh, absolutely. It has remarkable compensatory mechanisms. Take hemorrhage, for example. Blood pressure drops, so PT falls. This fall in PC, combined with local vasodilation due to reduced flow, shifts the Starling balance towards absorption. Fluid moves from the interstitium back into the capillaries, helping to restore blood volume. It's called autotransfusion. Similarly, when you stand up, PC in your legs increases. But myogenic responses in the arterioles can actually constrict slightly, reducing the number of open capillaries and thus reducing Auton-T, which helps limit the amount of fluid filtered out, preventing excessive swelling. The body constantly fine-tunes.
Amazing regulation. What was the third process? Penocytosis.
Penocytosis, or transcytosis. It's a minor player compared to diffusion and filtration for overall volume. It involves tiny vesicles budding off the endothelial cell membrane, engulfing a bit of plasma and solutes, moving across the cell's cytoplasm, and then fusing with the membrane on the other side to release their contents into the interstitial fluid. It's thought to be a mechanism for transporting very large lipid-insoluble molecules, like some proteins, across the capillary wall, albeit in very small quantities. The number of these vesicles varies between tissues.
Okay, a minor transport route. Now, flowing logically from microcirculation and fluid exchange, we need to talk about the lymphatic system. What's its crucial role here?
The lymphatic system is absolutely crucial, working in parallel with the blood circulation. It's a network starting with blind-ended, highly permeable lymphatic capillaries located in the interstitial spaces of most tissues. These capillaries merge into larger lymphatic vessels, which structurally resemble veins. They have thin walls and, very importantly, one-way valves to ensure lymph flows only towards the central circulation.
And what does it do?
Its primary indispensable role is to collect the excess interstitial fluid, the fluid that filtered out of the blood capillaries and wasn't reabsorbed, and, critically, to collect any plasma proteins that inevitably leak out of the blood capillaries. It then returns both this fluid, now called lymph, and the proteins back into the bloodstream, usually via the thoracic duct or right lymphatic duct, which empty into large veins near the heart.
Why is returning the protein so important?
Because proteins create that oncotic pressure. If the proteins that leak out weren't constantly removed by the lymphatics, They would accumulate in the interstitial fluid. This would raise the interstitial oncotic pressure, pulling more and more fluid out of the blood capillaries, leading to severe progressive edema. The lymphatic system is the only way escaped protein gets back to the blood. It's essential for fluid balance.
Okay, vital for preventing swelling.
Yeah.
Any other functions?
Yes. As lymph flows through the lymphatic vessels, it passes through lymph nodes. These act as filters, trapping and removing foreign particles, bacteria, and cellular debris, playing a key role in your immune system. The thoracic duct also transports absorbed fats in the form of chylomicrons from your digestive system into the bloodstream and returns proteins that leak from the very permeable liver capillaries. Lymph flow isn't static. It increases whenever capillary filtration increases, whether due to higher capillary pressure, increased capillary permeability, or decreased plasma oncotic pressure. Edema occurs if the rate of filtration overwhelms the drainage capacity of the lymphatics, or if the lymphatic vessels themselves get blocked, say by infection, inflammation, or surgery.
A critical overflow and cleanup system. Okay, so with this fundamental understanding of hemodynamics, rheology of the vessels, and exchange under our belts, let's dive into how different parts of our body get the specific blood supply they need. Time for a deep dive into some specialized circulations, starting with the heart's own supply, the coronary circulation.
Right, the heart works tirelessly, so it needs a constant, precisely regulated blood supply. This comes via the right and left coronary arteries, which branch off the aorta right at its root. These arteries wrap around the heart and send branches deep into the myocardium, the heart muscle. Most of the deoxygenated blood then collects in the coronary sinus, a large vein on the back of the heart, which drains directly into the right atrium. There are also some tiny, unique vascular connections, arteriosinusoidal, arterioluminal, and the Bayesian vessels that allow a small amount of direct communication between myocardial vessels and the heart chambers themselves.
Okay. What factors control blood flow through these coronary arteries?
Several things are key. Physically, the pressure in the aorta is the primary driving force pushing blood into the coronaries. However, the most important factor regulating coronary blood flow minute to minute is changes in the resistance of the small coronary arterioles. And this resistance is exquisitely tuned to the heart's metabolic activity.
Supply meets demand.
Exactly. When the heart works harder, its oxygen demand goes up, and the coronary arterioles dilate, decreasing resistance and increasing flow. When demand drops, they constrict. Coronary blood flow also shows strong autoregulation. It stays relatively constant even if aortic pressure changes within a certain range, typically between 60 and 180 mmHg mean arterial pressure. This is largely a myogenic response, the vessels themselves reacting to stretch.
What about the heart squeezing itself? Does that affect flow?
Oh, absolutely. That's extravascular compression, and it's a major factor, especially for the left ventricle. During systole, when the thick left ventricular muscle contracts forcefully, it squeezes the coronary vessels embedded within it so hard that blood flow through them is minimal, almost stops. Flow can even briefly reverse in the larger epicardial arteries.
So the left heart mainly gets its blood between beats.
Precisely. Maximal blood flow into the left ventricular muscle occurs during early diastole, when the ventricle relaxes and the compression is released. Now, the pressure inside the heart wall is highest near the inner layer, the endocardium. You'd think that layer would get less blood. But remarkably, under normal conditions, diastolic flow compensates, ensuring that blood flow is pretty evenly distributed across the heart wall from outer epicardium to inner endocardium. The right ventricle, being thinner-walled and pumping against lower pressure in the lungs, compresses its vessels less during systole, so its flow pattern is a bit less dramatically phasic.
Interesting.
You can see the impact of this compression dramatically. If the heart suddenly stops beating in diastole or goes into ventricular fibrillation, where coordinated contraction stops, coronary blood flow immediately shoots up because that squeezing force is gone. Heart rate also matters. Tachycardia, a fast heart rate, reduces the time spent in diastole, cutting down the filling time for the coronary arteries, which can limit flow. Bradycardia, a slow rate, allows more diastolic filling time.
Okay. How does this play out clinically?
Well, one intervention is counterpulsation. An intra-aortic balloon pump can be inserted into the aorta. It inflates during diastole, pushing blood back towards the coronary arteries to enhance flow, and deflates rapidly just before systole, reducing the afterload the struggling heart has to pump against. It's used for patients with severely damaged myocardium. Also, in coronary artery disease caused by atherosclerosis, the damage is often worst in that inner layer, the subendocardium of the left ventricle. That's because its blood supply is the most vulnerable to being compromised when coronary pressure is low or diastolic time is short due to the compression effect.
What about nerves? Do they control coronary flow much?
It's complex. Sympathetic nerve stimulation does markedly increase coronary blood flow, but paradoxically, this is mostly an indirect effect.
Indirect.
The sympathetic nerves increase heart rate and contractility, making the heart work harder. This increases its metabolic demand, triggering powerful local vasodilation that completely overrides any direct vasoconstrictor effect the sympathetic nerves might have via alpha adrenergic receptors. There are some beta-2 receptors that cause dilation, but the dominant direct effect is constriction. The vagus nerve, parasympathetic, causes only slight dilation. So the bottom line is coronary resistance is overwhelmingly under local non-neural control. The metabolic needs of the heart muscle itself are the primary driver. Acetylcholine is interesting too. It causes vasodilation in healthy coronaries via NO release, but can paradoxically cause vasoconstriction if the endothelium is damaged by atherosclerosis. Highlights endothelial health again.
So metabolism is king for the heart's blood supply.
Absolutely. There's an incredibly tight link between myocardial metabolic activity, oxygen consumption, and coronary blood flow. This happens even in denervated hearts, proving it's local. When the oxygen supplied-man ratio decreases, the heart muscle cells rapidly release various potent vasodilator substances into the surrounding fluid. Key players include adenosine, nitric oxide, NO, activation of ATP-sensitive potassium channels, K-ATP channels, and maybe even hydrogen peroxide. These substances relax the coronary arterioles, increasing blood flow to precisely match the oxygen demand. It's a very sensitive feedback loop. Reactive hyperemia, that surge in blood flow you see after a brief period of coronary artery occlusion, is caused by the buildup of these vasodilators during the ischemic period.
And oxygen supply is flow limited, you said.
Critically flow limited. The heart muscle extracts a very high percentage of the oxygen delivered to it, even at rest. Unlike skeletal muscle, it doesn't have much capacity to extract more oxygen if needed. So if coronary blood flow drops significantly, oxygen delivery drops immediately because extraction is already near maximal.
What are the clinical implications of that?
Big ones. Myocardial stunning is one. After a brief period of ischemia, lack of flow, even if flow is restored, the heart muscle can remain temporarily dysfunctional, stunned for hours or even days. This might be due to intracellular calcium overload or damaging free radicals generated during the reperfusion. Then there's hibernating myocardium. This is when prolonged chronic ischemia leads to a persistent but potentially reversible mechanical dysfunction. The heart muscle essentially downregulates its function to survive on low flow. If flow is restored, say by bypass surgery, function can potentially recover.
What about collateral circulation? Can the heart grow bypasses?
Sometimes. Normal human hearts don't have many pre-existing functional connections between major coronary arteries. However, if a coronary artery narrows slowly over weeks or months, collateral vessels can develop from tiny pre-existing channels. This growth seems to be stimulated by the increased shear stress in these small vessels and by growth factors, particularly vascular endothelial growth factor, VEGF, released by the oxygen-starved ischemic tissue. VEGF promotes new vessel growth, angiogenesis, vasodilation, and increases permeability, all trying to improve flow to the affected area.
Can we encourage this surgically?
Attempts have been made, but honestly, surgical efforts to promote collateral growth haven't proven much more effective than the body's natural response. For significant blockages, the standard treatments are coronary artery bypass grafting, CABG, or percutaneous coronary intervention, PCI, like angioplasty with stents, to physically open or bypass the blockage. Medications are also crucial. Organic nitrates, like nitroglycerin, release NO, effectively dilating coronary arteries, especially larger ones, and importantly, they also reduce the heart's oxygen demand by dilating veins, reducing preload. They don't mess with the heart's natural autoregulation. Calcium channel blockers also cause coronary vasodilation. Beta blockers help by reducing heart rate and contractility, lowering oxygen demand, and indirectly increasing flow by lengthening diastolic filling time.
What's coronary steel? That sounds bad.
It can be very dangerous. It happens typically in patients who already have significant coronary artery disease, like a tight stenosis in one artery while others are relatively normal. If you give a potent coronary vasodilator, like dipyridamole, which blocks adenosine uptake, increasing its effect, it will strongly dilate the healthy, non-stenosed vessels. This dilation in the healthy vessels can actually steal blood flow away from the diseased vessel, which might already be maximally dilated beyond the stenosis due to ischemia. So blood follows the path of least resistance to the healthy areas, worsening the ischemia in the territory supplied by the narrowed artery. It's a critical consideration when choosing diagnostic tests or treatments.
Wow, a real paradox of treatment. Okay, let's shift from the heart to the body's surface, the skin. You mentioned that circulation is mainly about temperature, not so much feeding the tissue.
That's right. The oxygen and nutrient needs of the skin itself are relatively small. Its primary circulatory function is regulating body temperature. Skin blood flow can vary enormously from very low in the cold to very high in the heat to help the body conserve or dissipate heat.
How is it regulated? Mostly nerves.
Primarily neural control, yes. The skin has two main types of resistance vessels we need to consider: regular arterioles and specialized structures called arteriovenous AV anastomoses. These AV anastomoses are like short circuits found mostly in exposed areas like fingertips, palms, toes, ears, nose, lips. They directly connect arterioles to venules, completely bypassing the superficial capillary beds.
Shunts, basically.
Exactly. And these AV shunts are almost exclusively under sympathetic neural control. They don't respond much to local metabolic factors, and remarkably, they don't show autoregulation or reactive hyperemia like most other vessels do. The regular skin arterioles, however, do show those properties.
And clinically.
A classic example is Raynaud's disease or phenomenon. Individuals experience episodes of exaggerated sympathetic vasoconstriction in their fingers and toes, usually triggered by cold or emotional stress. The vessels clamp down so hard it causes ischemia, making the digits turn white, then blue, and it can be quite painful. It's an overreaction of that sympathetic control.
Okay, so sympathetic nerves cause constriction. How does the skin vasodilate to lose heat?
Good question. Sympathetic stimulation generally causes vasoconstriction via norepinephrine acting on alpha receptors. Release of this tonic vasoconstriction allows passive dilation, but there's also an active vasodilation mechanism linked to sweating. Specialized sympathetic cholinergic fibers innervate sweat glands. When activated, e.g. by heat, they cause sweating, but they also trigger the local release of substances like bradykinin, which is a potent vasodilator. This helps increase blood flow to the skin surface to maximize heat loss. Higher brain centers also influence skin blood flow. Think blushing with embarrassment or turning pale with fear.
And temperature itself.
Temperature has direct effects too. Cold causes generalized cutaneous vasoconstriction, especially in hands and feet. This is partly a reflex via the hypothalamus and partly a direct local effect of cold on the vessels themselves. Prolonged severe cold can sometimes trigger a paradoxical secondary vasodilation, maybe to prevent tissue damage like frostbite. Heat, conversely, causes generalized vasodilation to help radiate heat away, and the body uses countercurrent heat exchange. Major arteries carrying warm blood down a limb lie close to major veins carrying cool blood backed up. Heat transfers from artery to vein, warming the returning blood and cooling the arterial blood before it reaches the extremity. This helps conserve core body heat in the cold and can work in reverse to help dissipate heat in warm conditions.
Clever design. Does skin color tell us much?
Not as much as you might think about flow rate. Skin color is mainly determined by pigment, but also by the amount of blood in the superficial venous plexuses and how oxygenated that blood is. So you can look pale, constricted vessels, less blood, or ruddy, dilated vessels, more blood, or even blue, cyanotic, lots of deoxygenated blood in slow-flowing vessels. But pale skin doesn't necessarily mean zero flow, and red skin doesn't always mean high flow through the exchange capillaries. The AV shunts complicate the picture.
Good point. Okay, let's move on to skeletal muscle. Huge part of our body mass, and its blood flow needs must vary massively with activity.
Massively is right. Blood flow in skeletal muscle is directly proportional to its contractile activity. It also varies by muscle type. Red muscle fibers, designed for sustained aerobic activity, generally have higher resting flow and capillary density than white muscle fibers, which are geared for quick bursts. At rest, muscle blood flow is actually quite low. Many capillaries are closed or only intermittently perfused. But during intense exercise, muscle blood flow can surge, increasing by 15 to 20 times the resting level. It's a huge dynamic range.
How is that regulated? Nerves or local factors?
It's a fascinating interplay. At rest, sympathetic vasoconstrictor fibers, releasing norepinephrine onto alpha-1 receptors, maintain a basal level of tone, keeping vessels somewhat constricted. Low doses of epinephrine from the adrenal gland can actually cause vasodilation via beta-2 receptors in muscle vessels. And the baroreceptor reflex strongly influences sympathetic outflow to muscle, making muscle vasculature crucial for regulating overall blood pressure simply because there's so much of it.
But during exercise?
During exercise, local metabolic factors completely take over. They dominate and override the neural sympathetic control. As muscle contracts, it produces metabolites, things like adenosine, potassium ions, lactate, CO2, causing acidity. These accumulate and act as powerful local vasodilators, opening up the arterioles and precapillary sphincters to dramatically increase flow to meet the huge oxygen demand. It's called functional hyperemia. Physical factors also play a role. Arterial pressure, tissue pressure changes during contraction, blood viscosity, and that mechanical squeezing effect of muscle contraction itself. It momentarily restricts arterial inflow, but powerfully enhances venous outflow, acting like that auxiliary pump we discussed, helped by the venous valves.
A very dynamic system indeed. Now let's turn to the brain. Consistency and protection seem key here. How is cerebral circulation unique?
Extremely unique and tightly regulated. The brain gets its blood from the internal carotid and vertebral arteries, which interconnect at the base to form the circle of Willis, a crucial safety feature providing alternative routes if one supply artery is blocked. We need to distinguish between the pile arteries, which run on the brain surface, have some nerve supply from outside, extrinsic, and have some collateral connections, and the parenchymal arterioles, which dive deep into the brain tissue itself. These parenchymal arterioles have intrinsic innervation, generally lack collaterals, meaning blockage often leads to localized damage, and are the primary regulators of blood flow to very specific brain regions.
And the skull makes things different.
Absolutely. The brain is inside a rigid box, the cranium. The total volume inside is essentially fixed. This means any increase in arterial blood inflow must be precisely matched by an equal increase in venous outflow. You can't just swell up inside the skull without raising intracranial pressure dangerously. And the brain is incredibly greedy and sensitive. It's only 2% of body weight, but uses 20% of your body's oxygen and maybe 25% of its glucose at rest. And it's exquisitely sensitive to ischemia. Just 5 seconds without flow can cause loss of consciousness. A few minutes can cause irreversible damage. So maintaining constant flow is paramount. Luckily, the brain primarily regulates its own blood supply through incredibly effective local mechanisms.
What are the key protective mechanisms?
Several. There's the blood-brain barrier, BBB, the intrinsic autoregulation of flow, and functional hyperemia linking flow to activity. The BBB is critical. It's formed by specialized endothelial cells with extremely tight junctions between them, plus interactions with other cells like parasites and astrocytes. It tightly controls what gets from the blood into the brain tissue, regulating ions, nutrients, and keeping out toxins and pathogens. The whole complex microvessels, parasites, astrocytes, neurons is now often called the neurovascular unit. Parasites seem important for regulating capillary diameter and promoting those tight junctions. Dysfunction of this unit is implicated in many neurological diseases.
What about nerve control of brain vessels?
It's relatively weak compared to other areas. Sympathetic nerves are present, but their control over baseline flow is modest. Parasympathetic nerves cause only slight vasodilation. Sympathetic effects might become more important in protecting the brain during extreme events, like preventing excessive pressure transmission during sudden severe hypertension, but day-to-day, local control dominates.
So how does the brain control its own flow locally?
Total cerebral blood flow is remarkably constant, thanks to powerful autoregulation. It's a complex interplay of myogenic responses, vessels reacting to stretch, metabolic signals, and perhaps some local neural reflexes. But even more impressive is the regional control. Blood flow is tightly coupled to local neuronal activity. If you wiggle your finger, blood flow increases precisely in the corresponding area of your motor cortex, almost instantaneously. Same for reading, listening, thinking activity drives flow. Glucose uptake matches this regional activity perfectly too.
How does that coupling work? How does neuron activity signal the vessels?
The neurovascular unit is key here. Astrocytes, a type of support cell, seem to act as intermediaries. When neurons become active, they release neurotransmitters. These can stimulate nearby astrocytes. The activated astrocytes then release substances like potassium ions or trigger other signaling pathways involving calcium waves, prostaglandins, etc., that ultimately act on the smooth muscle of the nearby parenchymal arterioles. For example, astrocyte release of potassium through specific channels, BKCA channels, can hyperpolarize the smooth muscle cells, making them relax, causing vasodilation and increased blood flow precisely where the neuronal activity is happening. It's incredibly localized and rapid.
Amazing cellular communication. What are the key chemical signals involved in this local control?
Several factors work together. Extracellular potassium, K+ levels, rise rapidly around active neurons during hypoxia or seizures. At physiological increases, K+ causes vasodilation. Very high levels can paradoxically constrict. Carbon dioxide, CO2, and pH are extremely potent regulators. CO2 easily diffuses across the BBB and into smooth muscle. It gets converted to carbonic acid, lowering pH, increasing acidity. Acidity in the cerebrospinal fluid and brain tissue causes marked vasodilation, possibly via effects on calcium signaling and those BKCA potassium channels in smooth muscle. The BBB is crucial because it largely prevents hydrogen ions, H+, from the blood itself from directly affecting these arterioles. It's the brain's internal pH that matters most.
In clinical.
A classic example is the Cushing's phenomenon or reflex. If intracranial pressure rises dramatically, for example, due to a tumor or bleeding, it can start to compress cerebral arteries, threatening blood flow. The brainstem detects this and triggers a powerful systemic sympathetic response, causing a massive increase in systemic arterial blood pressure. This hypertension is an attempt to overcome the intracranial pressure and maintain cerebral perfusion.
A desperate measure.
It is. Adenosine is another important local vasodilator in the brain. Its levels increase very rapidly within seconds in brain tissue whenever there's an imbalance between oxygen supply and demand, like in hypoxia or ischemia. And unlike K+ers, its levels tend to stay elevated as long as the imbalance persists. So it's likely a combination of these local factors, pH changes from CO2, potassium release, adenosine accumulation working in concert to constantly adjust blood flow to meet the brain's fluctuating metabolic needs, both globally and region by region. Cerebral circulation shows excellent autoregulation, keeping flow constant over a wide range of mean arterial pressures, roughly 60 to 160 millimol Hg. Below 60, flow starts to fall. Above 160, the system can get overwhelmed and flow may increase dangerously. And things like severe hypercapnia, very high CO2, can actually abolish autoregulation, making brain blood flow passively dependent on blood pressure.
Such tight control. Okay, let's move down to the gastrointestinal or mesenteric circulation. What's unique there?
The GI tract gets its blood from the mesenteric arteries, which form this really extensive network in the gut wall, especially in the submucosa. One very unique feature is found in the intestinal villi, those tiny finger-like projections responsible for absorbing nutrients. They have a specialized countercurrent exchange system.
Countercurrent. How does that work in a villus?
The main arteriole runs up the center of the villus, and the capillaries and venules loop back down near it. Blood flows up the arteriole and down the venules in opposite directions in close proximity. This allows oxygen to diffuse directly from the arteriole across to the venule, especially when blood flow is slow. It's efficient for oxygen delivery under normal conditions, but
There's a downside.
there's a significant downside. If intestinal blood flow becomes very low, like in shock states, this oxygen shunting can become so efficient that very little oxygen actually reaches the capillaries at the very tip of the villus. The cells there become starved of oxygen and can die, leading to necrosis and breakdown of the mucosal barrier. It makes the villus tips quite vulnerable to ischemia.
Wow, an efficiency that can backfire. How is gut blood flow regulated?
Neural control is almost exclusively sympathetic. Increased sympathetic firing via alpha-1 receptors strongly constricts both the resistance arterioles and the capacitance vessels, veins, in the gut. This is important during fight or flight responses or even aggressive behavior. Strong sympathetic outflow shunts blood away from the gut, which isn't critical for immediate survival, towards more vital organs like skeletal muscles, heart, and brain.
Okay. What about autoregulation?
Autoregulation in the gut isn't as strong or precise as in the brain or kidney, but it exists. It seems primarily driven by metabolic factors. Adenosine is thought to be a key mediator here. Its levels rise during low flow states or during active absorption of food. Potassium and changes in osmolality might also play a role. Interestingly, the gut seems to regulate its oxygen consumption more tightly than its blood flow. It tries to maintain constant oxygen uptake, even if flow varies somewhat. And there's functional hypersemia here, too. After you eat a meal, intestinal blood flow increases significantly to support the processes of digestion and absorption. This is mediated partly by absorbed nutrients themselves, like glucose and fatty acids, and partly by the release of various GI hormones, such as gastrin and cholecystokinin, CCK.
So eating ramps up the flow. Okay, next stop, the liver.
Yeah.
It has that unique dual blood supply and acts as a reservoir.
That's right. The hepatic circulation is unique. The liver gets blood from two sources. The portal vein delivers about 75% of the total liver blood flow. This blood is deoxygenated because it's already passed through the capillaries of the stomach, intestines, spleen, and pancreas, picking up absorbed nutrients and metabolic products. The remaining 25% of flow comes from the hepatic artery, which supplies fully oxygenated blood directly from the aorta.
So mostly used blood plus some fresh arterial blood.
Exactly, but here's the interesting part. Even though the hepatic artery supplies only 25% of the flow volume, it delivers about 3/4 of the oxygen consumed by the liver. So the arterial supply is critical for oxygenation. Both portal, venous, and hepatic arterial blood mix as they flow through the liver's specialized capillaries, called sinusoids. These sinusoids are very wide and leaky, allowing intimate contact between the blood and the liver cells, hepatocytes. Pressure in the portal vein is normally low, around 10 mmHg. Pressure within the sinusoids is even lower, only 2 at 3 mmHg higher than the pressure in the hepatic veins exiting the liver. This low pressure system means that liver fluid exchange is very sensitive to changes in downstream pressure, like central venous pressure.
Does the liver regulate these two flows?
There's a degree of interaction. If flow decreases in one system, say the portal vein, flow tends to increase in the other, hepatic artery, and vice versa. It's called the hepatic arterial buffer response. It helps stabilize total liver blood flow and oxygen supply, but the compensation isn't perfect. The portal venous system itself doesn't really auto-regulate. Its resistance tends to stay constant or even decrease as pressure rises. But the hepatic arterial system does autoregulate, maintaining relatively constant flow despite changes in arterial pressure. Adenosine seems to be involved in mediating this arterial autoregulation. The liver is very good at extracting oxygen, so it tends to maintain constant oxygen consumption even if delivery fluctuates somewhat. And unlike the intestinal villi, the liver sinusoids don't seem to have a significant countercurrent exchange mechanism for oxygen, which probably protects liver cells from the kind of tip hypoxia seen in the gut.
And the reservoir function.
Yes, the liver is a major blood reservoir. It normally holds a significant chunk of the body's total blood volume, maybe around 15%. Sympathetic nerve stimulation strongly constricts the capacitance vessels within the liver, mainly the veins. Under conditions like hemorrhage, this sympathetic constriction can rapidly expel about half of the liver's blood volume, maybe 300, 400 milliliters into the central circulation, providing a crucial autotransfusion to help maintain blood pressure. It's a vital backup system.
Clinically, what happens when liver circulation goes wrong?
Well, because of those leaky sinusoids and low pressure, if central venous pressure rises significantly, like in right-sided heart failure, pressure backs up into the liver sinusoids. This forces large amounts of low-protein fluid out into the abdominal cavity, leading to ascites. Also, if the liver becomes scarred and fibrotic, as in hepatic cirrhosis, often due to chronic alcohol abuse or hepatitis, the resistance to blood flow through the liver skyrockets. This causes pressure in the portal vein to rise dramatically, portal hypertension. Portal hypertension leads to ascites, but also forces blood to find alternative routes back to the heart, bypassing the liver. This often causes veins in the esophagus and stomach to enlarge massively, forming fragile esophageal varices. These can rupture easily, causing catastrophic, often fatal internal bleeding. Sometimes surgeons create a porticovale shunt, artificially connecting the portal vein to the vena cava to bypass the liver and relieve the pressure, but that has its own complications.
Serious consequences.
Yeah.
Okay, it's astounding how specific these adaptations are. Finally, let's explore one of the most incredible circulatory transformations of all. The journey from life inside the womb to independent breathing fetal circulation and the dramatic changes at birth.
It truly is remarkable. Fetal circulation is fundamentally different because the lungs are collapsed, fluid-filled, and non-functional for gas exchange. The fetus gets all its oxygen and nutrients from the mother via the placenta and the umbilical cord.
So the whole system is plumbed differently.
Completely. Oxygenated blood comes from the placenta via the umbilical vein. To ensure this precious oxygenated blood reaches vital organs quickly, the fetus has 3 major shunts or bypasses. First, the ductus venosus allows about half the oxygenated blood from the umbilical vein to bypass the liver sinusoids and flow directly into the inferior vena cava. Second, inside the heart, the foramen oval, an opening between the right and left atria, allows much of the relatively well-oxygenated blood returning to the right atrium from the inferior vena cava mixed with ductus venosus flow to shunt directly across to the left atrium, bypassing the right ventricle and the pulmonary circulation. Third, the ductus arteriosus connects the pulmonary artery directly to the aorta. Because pulmonary vascular resistance is extremely high in the fetus due to collapsed lungs and low oxygen, most of the blood pumped by the right ventricle gets shunted through the ductus arteriosus into the descending aorta, bypassing the lungs almost entirely.
So the lungs are largely bypassed.
Yes. In the fetus, the right and left ventricles effectively pump in parallel into the systemic circulation, unlike the series arrangement after birth. Only about 10% of the combined ventricular output actually flows through the fetal lungs. The left ventricle pumps blood mainly to the head, brain, and upper extremities, receiving the most oxygenated blood via the foramen ovale. The right ventricle pumps blood mainly through the ductus arteriosus to the lower body and back to the placenta via the umbilical arteries. Oxygen saturation, therefore, varies in different parts of the fetal circulation, with the liver, heart, and brain strategically receiving the highest levels.
But fetal oxygen levels are generally low, right? How do they manage?
Fetal arterial PO2 is indeed low compared to adults, maybe only 25-30 mmHg. But it's adequate for two main reasons. First, fetal hemoglobin, HbF, has a significantly higher affinity for oxygen than adult hemoglobin, HbA. Its oxygen dissociation curve is shifted to the left.
Meaning it grabs oxygen more easily.
Exactly. It allows the fetal blood to effectively pull oxygen from the maternal blood across the placenta, even at low PO2 levels. Second, the fetus compensates with a higher hemoglobin concentration and higher cardiac output relative to body weight. Also, early in gestation, fetal heart muscle cells have very high levels of glycogen stores, providing an energy reserve that helps protect the heart against periods of hypoxia. Clinically, if a fetus experiences significant hypoxia, its heart rate often increases fetal tachycardia as a compensatory response.
A very well-adapted system for life in the womb. But then comes birth. You said it's a rapid, dramatic restructuring. What actually happens in those incredible first moments and days?
It's arguably the most rapid and profound physiological transition a human ever undergoes. It's a cascade of events triggered by the first breath and clamping the umbilical cord. First, the umbilical arteries and vein constrict very forcefully almost immediately after birth. Their walls are thick and muscular, and they react strongly to the trauma of delivery, stretching, clamping, and especially the sudden exposure to higher oxygen levels in the external environment. This rapid constriction prevents major blood loss from the newborn. As flow through the umbilical vein stops, the ductus venosus also closes functionally within minutes to hours, diverting all portal blood through the liver sinusoids. The exact mechanism isn't fully understood, but seems related to the loss of umbilical flow.
Okay, and the lungs?
The lungs are key. The stimuli for the first breath include the transient asphyxia during birth, the sudden cooling of the body, and tactile stimulation. The respiratory center in the brainstem gets activated. As the baby takes its first breaths and the lungs inflate with air, this has a dramatic effect. Pulmonary vascular resistance plummets, dropping to maybe 10% of its fetal value within minutes. Initially, this isn't primarily due to increased oxygen levels, but rather the physical effect of air expanding the alveoli and mechanically stretching open the pulmonary vessels. Higher oxygen levels then help maintain this low resistance.
And this drop in lung resistance changes everything else.
It sets off a chain reaction. With low pulmonary resistance, blood flow through the lungs increases massively. This greatly increases the volume of blood returning from the lungs to the left atrium. At the same time, clamping the cord stops blood return from the placenta to the right atrium via the inferior vena cava. And systemic vascular resistance increases because the low-resistance placental circulation is removed. So, pressure in the left atrium suddenly becomes higher than pressure in the right atrium. This pressure reversal slams shut the flap valve covering the foramen ovale, functionally closing that shunt almost immediately. Anatomical fusion of the atrial septum usually takes weeks or months.
Wow, just like flipping a switch.
Right.
What about the ductus arteriosus?
With pulmonary artery pressure now much lower than aortic pressure, due to the drop in pulmonary resistance and rise in systemic resistance, blood flow through the ductus arteriosus reverses direction briefly. More importantly, the high arterial oxygen levels that occur after breathing starts to trigger active constriction of the smooth muscle in the wall of the ductus arteriosus. This constriction is progressive, usually leading to functional closure within 10-15 hours, and permanent anatomical closure. It becomes the ligamentum arteriosum within a few weeks. While it's closing, the turbulent flow through the narrowing ductus often causes a soft heart murmur, very common in newborns.
And the heart itself changes.
Yes, longer-term remodeling occurs. At birth, the right and left ventricular walls are about equally thick because they were both pumping against similar high resistances. Pulmonary via ductus and systemic plus placenta. The pulmonary arterioles also have thick muscular walls. After birth, as the right ventricle only has to pump against the low pulmonary resistance, its walls gradually thin somewhat. The pulmonary arterioles also remodel their muscle layer thinning. Conversely, the left ventricle, now solely responsible for pumping against the much higher systemic resistance, undergoes significant physiological hypertrophy. Its walls thicken considerably over the first weeks and months of life, adapting to its new, larger workload.
That's incredible remodeling. What if the ductus arteriosus doesn't close?
That's called a patent ductus arteriosus, or PDA. It's one of the most common congenital heart defects, especially frequent in premature infants whose ductal tissue may be less responsive to oxygen. A persistent PDA allows oxygenated blood from the high-pressure aorta to shunt back into the pulmonary artery, increasing pulmonary blood flow and potentially overloading the lungs and left heart. Fortunately, many PDAs, especially in preemies, can be closed pharmacologically using drugs that inhibit prostaglandin synthesis, like indomethacin or ibuprofen, or sometimes even acetaminophen. Prostaglandins help keep the ductus open in utero, so blocking them encourages closure after birth. If drugs don't work, the PDA can be closed very effectively either surgically or via catheter-based devices.
Phew, what an absolutely incredible and really comprehensive journey through the vasculature. We've unpacked everything from those basic fluid dynamics principles like the huge impact of vessel radius to the intricate workings of specialized circulations in the heart, brain, everywhere, and even those dramatic, perfectly timed changes at birth. This truly was a deep dive into mastery.
Indeed. And if we connect all this back to the bigger picture, it just underscores the profound elegance, the efficiency, and the remarkable resilience of the human body. It's truly stunning how basic physical laws are harnessed and precisely controlled at every single level to sustain life. From that fine-tuned local control in the microcirculation right up to the large-scale adjustments in venous volume, keeping blood returning to the heart. Getting a handle on these concepts at this depth, it really is key to unlocking a profound appreciation for both health and disease.
Absolutely. From the genius of arterial elasticity, smoothing out flow and saving the heart work, to the venous system acting as that critical adjustable reservoir and the microcirculation's vital exchanges dictating life at the cellular level, it's clear that really understanding these concepts like an elite professional would truly opens up a deeper appreciation for our own physiology.
You know, this raises an important question, something for you listening to ponder. Considering the remarkable adaptability and the intricate physical and physiological properties of the vasculature we've explored today, how might our ever-deepening understanding of all these details, the hemodynamics, the rheology, the local controls, the endothelial function, how might that continue to revolutionize medical treatments and preventative care in the future? Could it inspire entirely new ways of thinking about cardiovascular health?
A great question to leave us with. Thanks for joining us on this deep dive. We genuinely hope you've gained invaluable insights and feel truly well-informed, maybe even feel you've gained that mastery over this vital topic. Until next time, keep exploring, keep learning, and stay curious.